Hi, I'm Elisa Flum. I'm one of the Associate Program Directors at Lawrence Family Medicine Residency in Lawrence, Massachusetts. We know that every family medicine resident has varying career goals, and we've designed some integrated time within our 4-year family medicine residency to allow for intentional development of a skill set in a particular area of focus. We call this overarching curriculum our areas of concentration. I have some Lawrence Family Medicine faculty here with me today to help you understand our approach to individualized learning within our family medicine residency. Prospective residents do not have to choose their area of concentration until about mid-second year of residency, and then have some block time in their 3rd and 4th year to pursue their interests. We have 9 areas of concentration to share with you today, so let's get started.
Hello, my name is Julie Johnston, and I'm the Women's Health and Reproductive Health Coordinator for the area of concentration at Greater Lawrence Family Health Center. Here is a slide that shows a lot of the procedures and the conditions that our residents treat in this area of concentration. And I just want to note that all of this is framed in a reproductive justice model that is very important to us. And one of the innovations of this area of concentration was the addition of infertility treatment for our patients. As the case in many states, infertility treatment is not covered for Medicaid for patients who are referred out to a reproductive endocrine clinic, but is covered in the context of primary care. So this is something that we offer, ovulation induction with oral medications, and this happens a lot in our gynecology referral clinic where our AOC residents spend a lot of time. Here is a list of the goals of the area of concentration, and I want to assure everyone that all of our residents receive a really comprehensive gynecologic reproductive health curriculum. All residents are trained in IUD insertions and removals, endometrial biopsies, implants, insertions and removals, and we spend a great deal of didactic time with all residents for this training. However, there are residents who want to have a deeper dive, and these residents will train to competency in colposcopy. Some spend additional time training to competency in early pregnancy ultrasound, STD testing, and so forth. For residents who are interested, there's opportunities to do uterine aspiration for miscarriage management in our health center, and these AOC residents kind of get first dibs at those procedures. We move residents from becoming learners and doing more advanced procedures to actually precepting these procedures within the 4th year. And it is a great opportunity for us as faculty to observe residents participating as a preceptor. We're able to note this on evaluations, and many of our graduates from this AOC go directly into faculty roles. Advocacy is very close to my heart, and there's lots of opportunities for residents to participate in local, state, or national level advocacy within women's health or other areas. So here's a list of the additional experience that AOC residents receive. And this AOC was created looking at women's health fellowships, other reproductive fellowships across the country, so you will see many similarities. So as I mentioned, residents trained to competency in colposcopy. They sit for the ASCCP course, and then in their 4th year, they do take the ASCCP colposcopy exam. We have connections with pediatric and adolescent gynecologists who our residents spend time with. There is a 3-day STD intensive course. And then these are some of the more difficult procedures that our residents participate in the referral clinic staffed by family medicine physicians. So you might see an IUD that is missing its strings and have to do different procedures to remove that. There are more deeply placed implants that need removal, or referrals for patients who received a 2-implant system in another country and would like to have it out. There will be procedures like an endometrial biopsy that another clinician was unable to perform due to cervical stenosis that is referred for kind of additional techniques and possible dilation. We see a lot of gynecologic dermatology, and by spending the additional time in this referral clinic, you see a better breadth of those conditions and do more practice with more rare procedures such as peripheral cyst treatment and vulvar biopsies. In addition to these skills, we have a women's health email list that clinicians across all of Greater Lawrence can send in their difficult conundrums. And I think it's a great opportunity for residents to answer the questions. So they do a little bit of research They respond or involve us as faculty, and there's always faculty backup. So residents take turns kind of manning the email list. We involve residents in QI, teaching, and research in this area of concentration. So we have a lot of requirements in our curriculum, but there is a room for residents to tailor the training to their own needs. Currently, we have a resident pursuing additional time doing gender-affirming hormone therapy, another resident spending additional time in lactation clinic, learning different procedures and techniques for assisting patients with lactation. On the horizon, there is the potential for seeking NAMS, which is the menopause group certification, or additional training in vasectomy. This is what our AOC schedule looks like, which is probably similar to others in terms of the 20 longitudinal sessions, and this is in the gynecology referral clinic in the 3rd and 4th year, and then differing amounts of AOC block time between the 3rd and 4th year. So this is an example of a schedule. So typically 2 sessions in the referral clinic, a colposcopy session, an ultrasound session, and our AOC residents have precedence to go to a local reproductive health clinic where they can do additional procedures, STD training, counseling, and so forth. Our graduates have done a lot of great things over the years. Many go into immediate faculty positions. Many have started their own gynecology procedure clinics wherever they go. Some have done international abortion work and become reproductive health national leaders. I think everyone is grateful for the training, and we know that residents who complete this area of concentration definitely have a higher procedure volume upon graduation and are able to offer kind of more comprehensive services to their patients in this area of women and reproductive health.
Hi, everyone. I am Jenny Summers, Associate Program Director here at Lawrence Family Medicine Residency Program, and I am going to be talking about the hospital medicine area of concentration. This area of concentration was started 2 years ago by a couple of very motivated residents and also faculty who really felt the importance of having family medicine in the hospital and taking care of patients on the inpatient service was underrepresented in our residency program. And so we created this area of concentration to make really experts at hospital medicine. So we have all co-authored this, and you'll be seeing some pictures of some of our fabulous hospital medicine area of concentration residents. Lydia Rex and Juliet Casas have both helped me with this presentation. And then I am co-leading the hospital medicine area of concentration with Dr. Ricardo Camacho. Hospital medicine area of concentration is focused on several really important skills. And those important skills are advanced skills in hospital medicine, both in the intensive care unit and with running teams on our adult medicine inpatient service. Our hospital medicine area of concentration residents do quality of improvement projects that are invested in the hospital and on adult medicine, and they also present and are part of hospital committees. They do a little bit more acute care at Haverhill Street than continuity clinic to be really comfortable in the urgent care environment as well. The procedures that we're working towards in the hospital medicine area of concentration and that they're focused on are central lines, paracentesis, thoracentesis, and plus or minus intubations depending on where they want to work after graduation. The hospital medicine area of concentration has leadership as part of it, and part of that leadership is demonstrated by some of the projects that they have done so far. One of them is the Rapid Response Quality Improvement Project, and they also participate in case review, which is a case review committee which is focused on quality of patient care at the hospital. They participate in the Pharmaceuticals and Therapeutics Committee as well, and also in the design of the transition of care clinic back here at our Greater Lawrence Clinic. The transition of care clinic is after a patient is discharged from the hospital, then they move back to our clinic, and this is how we reintegrate them back into the community. Our hospital medicine area of concentration residents do a lot of teaching. They work on mock codes and rapid response teaching. They do medicine teaching on a regular basis, and they also created our intern survival guide. Some of the rotations that our hospital medicine residents do are additional medicine weeks, additional team leadership, additional ICU rotations, and then rotations with our hospitalists at Lawrence General. One of our residents will be working with the nocturnist next week, and she will be leading all of the codes. Another one of our residents has done extra time doing admissions in the afternoon and the evening to really learn all of the bread and butter hospital admissions that they need to know. Some of the conferences our residents have attended are Update in Hospital Medicine, which is done by Harvard Medical School, the Intensive Care Conference for the Non-Intensivists, which is also done by Harvard Medical School, and they have the ability to present at the Society of Teachers of Family Medicine and other family medicine conferences on their work. Some of the specialty rotations our hospital medicine area of concentration residents have done so far or are going to do in the future are anesthesia, neurology, nephrology, infectious disease, and plus or minus interventional radiology to get more procedures. Thank you so much for listening to our presentation on our hospital medicine area of concentration. Please feel free to contact me with any questions.
I'm Stephen Buttenwieser. I'm one of the core faculty at the Lawrence Family Medicine Residency, attending physician at the Greater Lawrence Family Health Center for the residency, and the director of the addiction medicine area of concentration. We've provided addiction care in a formal way for over 20 years here at the health center, prescribing buprenorphine, starting with a few physicians and growing pretty quickly into a formal program supported by a State Department of Public Health grant supporting a multidisciplinary team approach to addiction treatment here. We've had an area of concentration in addiction medicine since 2017. The backbone of that was really longstanding multidisciplinary outpatient addiction treatment program here at the health center, and then an addiction consult service, which was started by the first area of concentration resident and supporting faculty in 2018. There are currently 8 to 10 core and community faculty who are in particular dedicated to supporting the addiction area of concentration, 4 of whom are board certified in addiction medicine. The team also includes nurse case managers, recovery coaches, community health workers that are dedicated to addiction care, behavioral health counselors, and prescribers. The goal of the addiction area of concentration is to provide advanced training to residents so that they can provide high-level, essentially specialty addiction care in a variety of settings, inpatient and outpatient. The goal and expectation is they can serve as future consultants or practice leaders in their practice community resource for many different kinds of professional colleagues, be in a position to train other students and professionals in addiction medicine, and certainly to be in a position to be involved with kind of advanced and involving concepts in the field. The core educational principles are to become advanced in evaluation, diagnosis, and treatment and recovery of people with substance use disorder, and to really become also expert in the assessment and treatment of medical, psychiatric, and social complications of substance misuse. The core curriculum involves teaching and learning in areas of neurobiology of addiction, alcohol and drug pharmacology, comprehensive full spectrum treatment of substance use disorder, in particular pharmacotherapy for substance use disorder, and becoming really advanced in psychosocial interventions, concepts of harm reduction, motivational interviewing. And there's a particular focus in this track on the care of vulnerable populations. Some of the approaches that we take are to really ground residents in this track in concepts of screening, brief intervention, referral, and treatment, understanding addiction as a chronic disease, being comfortable in both the inpatient and outpatient setting, particularly with advanced familiarity and skill in the inpatient treatment of opioid use disorder and alcohol use disorder, and in the outpatient medical treatment of opioid use disorder, alcohol use disorder, tobacco use disorder, and also to develop some approaches for stimulant use disorder and benzodiazepine use disorder. Another area that residents in this track develop advanced training in is in particular in opioid use disorder in pregnancy. Also, a lot of attention is paid to safer opioid prescribing and also to management, medical and otherwise, of chronic pain. Many of the residents who choose this track are also interested in particular in training in HIV care and viral hepatitis care. So we have a close relationship with the residents that are training in that addiction medicine track and the HIV and viral hepatitis track. And there's a lot of co-learning that goes on among the two groups. The core clinical experiences are there's a inpatient addiction consultation service in our hospital. It's a 180-bed community hospital, and we provide consult service for general medical surgical patients in the intensive care unit, the emergency department, also maternity, and there is a pediatrics floor. We have robust office-based addiction treatment program here at the health center. There are various clinics that residents participate in. They also have a very well-developed primary care panel of patients that are at various stages of treatment and recovery with substance use disorder. We have a mobile unit, Bridge Clinic, where residents in this tract spend a good amount of time, in particular, linking people to early and direct linking to methadone care, follow-up from hospitalization treatment, and providing early access to harm reduction services. There's also a robust participation in local methadone treatment programs with our core faculty. So at the completion, our graduates have graduated in advanced concepts of addiction training, and some of the graduates include the current medical director of addiction services at a 400-bed community hospital, a recent graduate providing full spectrum addiction care, both at a community health center and also at a methadone treatment program. Another resident is a street medicine provider at a urban healthcare for the homeless program. And two other residents are providing robust addiction treatment in a kind of a dual role at a community health center. And we expect to continue to be able to provide education to support graduates to be expert colleagues and consultants and practice leaders in their chosen community.
Hi, I'm Elise LaFlamme, and I'm the director of our surgical maternity care area of concentration. And I'd love to spend some time today to talk about how our curriculum is integrated in our 4-year family medicine residency, as well as how it prepares residents with procedural skills to practice alongside family medicine colleagues, as well as OBGYN colleagues in their future careers. At Lawrence Family Medicine Residency, we started here in 1994 and then started a 12-month OB fellowship in 2005. This was a 12-month fellowship after family medicine residency graduates completed their training elsewhere or here, and they could apply to be in our fellowship. We had 19 graduates within 10 years. And then in 2012, we applied and were accepted into the ACGME length of training pilot and switched to be a 4-year residency. In 2014, we transitioned our OB fellowship into an integrated high-risk and surgical obstetrics area of concentration within our 4-year family medicine residency. And we since have graduated 13 residents from this area of concentration in the past 8 years. Our advanced maternity, surgical obstetrics, AOC, and all of the rest of the area of concentrations, our residents decide which area of concentration they'd like to choose in the fall of their second year. So they have about a year to kind of expose themselves to the different options and think about how they think their career will develop. We typically have 2 residents per class in this particular area of concentration, so 4 residents at any given time, because we have area of concentration residents in their 3rd year and 4th year of residency. All of these experiences are spread out over the 3rd and 4th year of residency, and generally residents will have about 28 weeks of inpatient labor and delivery experience over those 2 years. And this is mostly on this overview of our full curriculum. The slate gray color as well as the purple color are maternity care specific experiences. And then also the blue on the right is our elective time, which can be used here as well. Another higher level overview of our area of concentration. This is a comparison of what the OB fellowship used to look like, but really we've put all of those same experiences that you would have in an OB fellowship and integrated them over the 3rd and 4th year of residency, including at least 28 weeks on labor and delivery. Our residents in the area of concentration take home call for all C-sections, and we cover all C-sections in the entire hospital 24/7, 365 days a year, split between the 4 residents. You also have longitudinal sessions throughout those 2 years where you work very closely with our obstetric fellowship trained family physicians, and there's actually 13 of us that do C-sections. You work with us in our high-risk obstetrics clinic, seeing patients antenatally, prenatally, and kind of working with problems such as type 2 diabetes, type 1 diabetes in pregnancy, high blood pressure in pregnancy, lots of complications to pregnancy. We also have training in our first trimester ultrasound clinic, as well as ensuring that our graduates are also instructors prior to graduation. Looking at some of our numbers in procedures for our graduates, what I'd like to point out is that to get certification by the American Board of Physician Specialties, which is the only way to get family medicine obstetric boarded in our country right now, you need 70 C-sections as primary surgeon and 60 vaginal deliveries to sit for those boards. And all of our graduates are very far surpassing those numbers with their final procedure numbers at graduation. This slide also shows that bar in red and how all of our graduates are far surpassing those requirements. In summary, the benefits of an integrated training model with this area of concentration are many. The high points are our procedural experience based on numbers is much higher than the bar. And so our graduates are coming out with confidence and competence equal or surpassing that of an OB fellowship experience. You're also having these 2 years instead of just 1 year to develop your confidence in the OR. And I think that's really important as you go on to put yourself in challenging situations with colleagues that may be both family medicine physicians and OB-GYNs. You're also able to mentor junior residents, both within the area of concentration and other family medicine residents in your team. As I said, there's 13 of us that do C-sections. So in addition, the 4 area of concentration residents every year, we have a large group and team that we use for support and morale. And I think that's really important. Finally, we have a realistic schedule for what your future career might look like. So you're integrating family medicine, continuity care practice, as well as obstetrics practice in this area of concentration, and really getting a sense of what your future career might look like, as opposed to just having a dedicated maternal child health obstetrics year. And so this is a great way to test out your future. Also, lots of times for projects, scholarly work, involvement in research, which can be good for your CV, but also just kind of projecting your career goals for the future as well. I'd also like to add that the American Board of Physician Specialties, which is the only board that certifies family medicine physicians in obstetrics, does recognize our program as a OB fellowship equivalent. So graduates from our program are able to sit for and apply for board certification through the American Board of Physician Specialties. Thank you for joining us. And if you have any questions, please reach out at my email, which is listed on the bottom of the slides.
Hi, everyone. My name is Dr. Jonathan Lichkis. I am the co-director of the Health Systems Leadership Area of Concentration. I'm here along with...
Hi, everyone. I'm Dr. Tuan Roy. I co-direct the curriculum with Jonathan, and we have here...
I'm Dr. Claire Trachtman. I'm a 4th-year resident and chief resident at Lawrence Family Medicine Residency, and we're going to show you the Health Systems Leadership Area of Concentration. We're going to talk through various components of health systems leadership today and about what our area of concentration could offer to you if you were a resident at Lawrence Family Medicine. And of course, we always find the best learning to be through a case. So let's walk through a case in the lens of a resident. So imagine you're in clinic and you're seeing a newborn for a walk-in visit. It's a 10-day-old baby. They were born at the local high-volume hospital. They had some complications that you know of. Mom is there in the visit, and she's been feeling somewhat down. Your MA does the appropriate depression screening for her, which comes out positive. Mom tells you that she doesn't have a lot of food at home and isn't getting WIC services yet. Now, if you were to take this case and separate it from the medical side of things and start to think through the lens of a systems thinker, you might ask yourself several questions. Number one, why is this newborn coming for a walk-in visit? Can we improve access to clinic for patients who are newly discharged from the hospital or newborns? What do we mean by some complications? Is there a better way to have an improved handoff process from the hospital? When we're talking about positive depression screenings or all social determinants of health that we know greatly impact health, how do we ensure that mom is going to get treatment? Can we get behavioral health involved right from the get-go? And finally, when talking about things like food, what are other processes that we can build to approach social and structural determinants of health and to support our patients in their lives outside of the clinic? So all of these elements really are incorporated into health system science, which is a pillar of medical education that encompasses various parts of healthcare. And you can see all around our patient, family, and community are various components in a lens of systems thinking, which is what we're hopefully going to show you a little bit about today. at Lawrence Family Medicine. We have our 4-year curriculum overview. So in addition to a more traditional 3-year curriculum with continuity care, adult medicine, pediatrics, we've integrated throughout residency training dedicated time in health systems leadership. And specifically, if people are interested in this and have aspirations to go into clinical leadership, do more quality improvement, or overall just build their systems thinking abilities, they can choose to do the health systems leadership area of concentration like I have. So talking about our curriculum, for one, it's a longitudinal curriculum. So we all get exposure to this starting from intern year. This involves working in team-based care in our integrated care teams, working through the Institute for Healthcare Improvement basic certification, which everyone does as soon as they come in as an intern, having your own dedicated QI project, which could be related to your AOC or other interests. And there are also components of advocacy, leadership, population health, patient safety as well. When we think about specific rotations, there is the clinical chief rotation, which occurs in the 4th year, which is a longer experience that allows residents to have a more integrated experience into clinical leadership, going to leadership meetings and being involved in the management and day-to-day ongoing tasks of working in a busy federally qualified health center. When thinking about the leadership component of the curriculum, we think about the core components of personal leadership development, experiential learning, and teaching and mentorship. When thinking about leadership development, there are lots of opportunities. Many of us go over to our hospital to do a dedicated leadership opportunity and year-long curriculum there, as well as continued teaching and mentorship within the residency here. And then within the area of concentration, we have typically 1 to 2 residents per year, and we are given dedicated time throughout our 3rd and 4th years to explore our interests within the area of concentration. For me, that means a lot of time doing quality improvement and thinking about how can I build a better clinic in the future. And typically, residents get about 6 weeks in the 3rd and 4th years, as well as sessions throughout the year, and dedicated funding to pursue conferences, additional training, and anything else that could be beneficial to their education in health system science. When thinking about leadership development and reframing the personal, experiential, and teaching goals, you can see that there are many different components here, and the assessment and training are both important parts of the personal. You have the opportunity, or rather I have had the opportunity, to mentor QI projects and get involved in various committees. And there are lots of teaching experiences, both for peers and potentially outside of the residency as well, at national conferences and other places to disseminate information. So to tie it all together and bring us back to our initial case, thinking about this through the lens of a systems champion, now you are in clinic and you're seeing a newborn for a scheduled visit now that they've come out of the hospital. They were born at the local high-volume hospital with some complications, and although the visit was not scheduled originally, they had clinical outreach so that they were able to have a visit scheduled at discharge. Mom is there, continues to have a positive depression screen, so she's set up with a same-day visit with a therapist to start her treatment. And finally, Mom says that during her prenatal visits, she had WIC and SNAP services for food assistance set up prior to her baby being born, so that she didn't have to deal with those stressors after her baby was born. And now she has close follow-up. So hopefully this gives you a good snapshot of what it means to be a systems thinker and what health systems leadership could offer to you here.
Hi, I'm Katrina Baumgartner. I'm the clinical and AOC director for HIV and viral hepatitis care at Greater Lawrence Family Health Center. We'll be talking a little bit about training family medicine residents in the HIV and viral hepatitis area of concentration at Greater Lawrence. First, we'll start off with Josh St. Louis, who is my colleague here.
Hi, my name is Josh St. Louis. I'm one of the core faculty at the Lawrence Family Medicine Residency and one of the HIV certified specialists who help to support the HIV AOC. In terms of resources for our area of concentration, we have a number of excellent resources that help to support resident learning. We have 5 AHIVM certified faculty members, all of whom are family medicine trained and all of whom have extensive clinical experience. We have a relatively large HIV patient panel of nearly 400 patients with quite high acuity, including many opportunities to manage different opportunistic infections. In terms of viral hepatitis, we also have nearly 1,000 patients with chronic hepatitis C and more than 150 with chronic hepatitis B as well that we manage primarily. In terms of adjacent disciplines for HIV clinical care, our residency and clinic have large and mature programs in a number of relevant adjacent clinical disciplines, including addiction medicine, gender-affirming care, colposcopy, and prenatal care. In terms of research and training opportunities, we have a relatively scholarly approach to our HIV area of concentration, and residents present both locally and nationally. On the left, you see two of our residents last year presenting at the Society of Teachers for Family Medicine annual conference, a workshop that they did on HIV prevention. On the right, you see our clinical team doing their FibroScan trainings. We're lucky to be one of the only FQHCs in the country with the ability to do transient elastography in our clinic, and our residents are taught to interpret the scans. And then in terms of community engagement, our clinic has a mobile health unit. We actually have 2 mobile health units now, a low barrier addiction medicine entry program, including a bridge clinic and a syringe services program, and quite close engagement with city and local community organizations to support patients. So I'll hand it back to Katrina.
The AOC HIV AOC structure was created with the goal to train family medicine residents into the doctors or patients with HIV and viral hepatitis care really need. And we kind of structured it in a way that you would be getting very high quality clinical didactic, self-paced and elective opportunity experiences. The clinical experiences are centered around our HIV comprehensive care clinics and viral hepatitis clinics that we provide through our health center, as well as exposure through our mobile health and bridge clinics that occur 3 times a week with an HIV specialist that residents can rotate through. We also have a unique opportunity where our HIV AOC residents are able to consult on inpatients or persons that are hospitalized with HIV, whether related to their HIV or not. Throughout the continuity panel as well, our residents in the AOC have 15 to 20 patients with HIV that are assigned to them for ongoing clinical care that are precepted with our HIV specialists. Just by way of where we practice and our population, you also receive an extensive exposure to STD prevention and treatment and PrEP and PEP. Within our HIV, we have a variety of didactic experiences as well, monthly guided learning activities that are led both by our faculty that are HIV certified, as well as the current and kind of graduating AOC residents. We have monthly case conferences with our full HIV team, as well as case conferences that we have privileged to attend with the Tufts ID Fellows once a month. Additionally, we have open access to our HIV faculty for one-on-one learning sessions, as well as a robust location of practice in the Boston area with a lot of ID-focused conferences that are available and experts in the field locally. Our AOC is structured on a self-paced 18-month curriculum. It is based on the HIV national curriculum, but it also goes through primary readings and a lot of tutorials and things that are really relevant and hands-on. In addition to asynchronous precepting of complex cases, residents can also co-teach our monthly didactics for the general residency. They're integrated into our clinical practice space globally. They annually update our HIV primary care guidelines. And additionally, we have a lot of elective opportunities that overlap with the HIV specialty, including addiction medicine training, gender-affirming care, colposcopy, infectious disease, latent TB, a lot of different opportunities that residents are able to integrate into their practice in order to essentially become, at the end of the residency, HIV certified. And this AOC will really prepare you to take that learning into real clinical practice wherever you may serve.
I'm Suhani Bora. I am core faculty and director of the Integrative Medicine Fellowship here at Lawrence Family Medicine Residency, and I'll be talking to you about the Integrative Medicine area of concentration. I'm just going to read for you the scope of integrative medicine. It is the consideration of all factors that influence health, wellness, and disease, including mind, body, and spirit, the use of conventional and alternative methods to facilitate the body's innate healing response. The appropriate consideration is given to use of less invasive and less harmful interventions when possible, while addressing the whole person in addition to the disease. The concept that medicine is based on good science is inquiry-driven and open to considerations of new paradigms, and health care is best provided as a partnership between physician and patient. So what are the benefits of an integrative or whole health approach? One study that reviewed institutions who have implemented whole health have found that these institutions have better outcomes, improved patient experience, lower costs, and improved physician experience. Here at Greater Lawrence Family Health Center in Lawrence Family Medicine Residency, we've had a fellowship since 2004 when it was first approved by the American Board of Physician Specialties. In 2021, when we switched from having an after residency fellowship to bringing it within the residency, it was approved by the Academic Consortium for Integrative Medicine and Health. It was a 2-year curriculum. We've had 3 graduates, 3 current residents, and 2 residents will be joining us next year. This means that residents who graduate from the Integrative Medicine area of concentration are eligible to sit for the American Board of Integrative Medicine exam and become board certified. So the first aim of our fellowship, the first of 4, is social justice. Whole person care requires embracing cultural humility through listening to and learning from cultural and individual traditions, stories, and narratives. Residents will learn how to address social determinants of health as a part of integrative primary care and integrative consult clinic, and they'll use innovative, compassionate approaches in caring for patients with a history of trauma, addiction, and chronic pain. The next aim is self-care. We know that physician burnout is a public health crisis with many causes, and self-care may help mitigate its effects. The third aim is science. Residents will have an evidence-based approach in learning integrative medicine. And the last is skills. Residents will have an opportunity to learn a skill that they may implement throughout their 2 years of the fellowship. Just to give you an idea of the structure of the curriculum, all AOC residents will participate in weekly didactics. These are on Fridays from 1 to 2 on Zoom or hybrid. And all residents are faculty, which is 2 core and 2 community faculty, as well as alumni attend these didactics. We have a 2-year set curriculum. They'll also participate in group visits. We have currently 2 different types of wellness group visits, chronic pain and healthy weight. Residents will participate in integrative consult clinic, where you see patients referred to us by other clinicians. Residents will start with 1 hour per patient in the beginning. And you also have an opportunity to teach, whether it's scholarly work, presenting at conferences, or teaching other residents. As a part of the fellowship, residents will have 1,000 hours of training. 300 of those hours are clinically focused with a mixture of consult clinic, primary care, and group visits, 100 hours of live training or CME, and 200 hours of scholarly work. This is just a breakdown of those hours. Focusing on the didactic portion, didactics are 1 hour, as I said. The first year focuses on evidence-based medicine, the philosophy of integrative medicine, lifestyle, and health equity. The second year is an organ system-based approach. We also have a longitudinal curriculum, as you can see over here, which includes paying attention to health equity, cultural misappropriation, the impact of colonialism, physician wellness, and evidence-based medicine. The didactics are meant to cover information that you will need for the board exams. And this is just a list of some items that are covered on the boards. As you can see, it covers a wide range of topics, including nutrition, supplements, botanicals, and then extending to whole medical systems, lifestyle, prevention, and the practice of integrative medicine. The next portion of the curriculum is the integrative health consult service. So patients are referred to us by different clinicians in the system, primarily for chronic pain, but also for chronic fatigue, IBS, anxiety, depression, or a whole host of other topics. They all have an intake done by a coordinator on the phone. And then residents have an extended amount of time to do a full assessment intake and to come up with a whole health plan. The last year by didactics are group visits or wellness-based group visits. This is a way to address loneliness and also to encourage peer interaction. This is a picture from one of our most current groups on chronic pain. And I'll introduce you to Dr. Gabby Velasquez, who is a 4th-year resident in our area of concentration, to share her experience.
My name is Gabby Velasquez. I am a 4th-year resident in Lawrence, and my area of concentration is the integrative medicine area of concentration. And the reason that I chose to do integrative medicine for my concentration is that there's so many ways that over history humans have healed themselves. And I notice a lot of our patients gravitating towards more natural remedies and just like leaning toward their faith and spirituality. And I also come from a public health background. So for me, kind of this intersection of whole health healing, whole health approach, how our bodies heal themselves is really interesting to people. And it's a way to improve primary care, which is a public health issue. So for me, it felt like a really great fit for my area of concentration. I also chose to do it because I knew that it was fellowship equivalent. And I know that a lot of us come into this residency knowing that it's 4 years. So it's an extra year of training. So to be able to walk out with that extra year with another specialization or an eligibility for board specialization was really attractive to me as well. It's been great to be part of this group and to be part of this area of concentration. I actually feel so fulfilled, and I actually feel like I am doing the work that I set out to do when I chose to do primary care and family medicine. We talk so much about health equity and anti-racism and, decolonizing medicine as aspects to our training and our conversations, just because so much of this traditional knowledge that people have carried on for thousands of years over time in our medical system has sort of been erased. So to be able to elevate that knowledge again and just kind of help people through their own healing has been really rewarding as a primary care physician. And every aspect of the area of concentration has been really enjoyable. And I really enjoy our integrative medicine consultations, enjoy getting to know patients on a more holistic and just more robust level, talking to them during these consults. I enjoy giving the didactics every week. Just about every month we prepare these lectures, and it's actually really fun for me to read about these topics and teach my co-residents and my fellow faculty. So overall, it's been a really great experience.
Hi, I'm Dr. Christy Langenberg. I'm the Sports Medicine Director at Greater Lawrence Family Health Center and the Director of the Sports and Musculoskeletal Medicine Area of Concentration here at Lawrence Family Medicine Residency. I've been at GLFHC since 2016, providing primary care, including pediatric and prenatal care, as well as inpatient medicine rounding and doing sports and musculoskeletal medicine clinics. I'm also the school physician for 2 local high schools and run sports medicine clinics in their school-based health center. I'm excited to have the opportunity to give a brief overview of the Sports and Musculoskeletal Medicine AOC here at Lawrence Family Medicine Residency. Musculoskeletal complaints constitute between 20 and 40% of outpatient primary care visits. Some studies show that medical students and non-orthopedic primary care residents feel inadequately trained in musculoskeletal medicine and joint examination skills. Therefore, the primary goal of the Sports and Musculoskeletal Medicine AOC is to increase residents' knowledge and clinical skill set to have the confidence to diagnose and manage common musculoskeletal injuries in their own clinics, as well as deepen the knowledge of less common injuries and to know when to refer to other specialists. We aim to facilitate competency in palpation-guided and ultrasound-guided injections, as well as other musculoskeletal procedures. Here at Lawrence Family Medicine Residency, social justice and health equity is part of our mission, and musculoskeletal medicine is no different. We strive to provide culturally competent care and help decrease inequities by providing musculoskeletal care to those that may otherwise have difficulty accessing it. Nationally, exploring health equities in sports medicine is in its early stages, but we will incorporate review of the latest research during our monthly journal club meetings. AOC residents may have different career goals, and the AOC and its elective time is flexible to be able to tailor residents' experiences to these goals. If a sports medicine fellowship is the goal, the AOC will help and aid in preparation for application to the fellowship, but it's not required. Specific experiences within the AOC include longitudinal experience covering high school football games at Lawrence High School and Greater Lawrence Technical School, as well as working in sports medicine clinics at the school-based health centers. Residents will help cover the Boston Marathon as their mass participation event. There's ample opportunity to organize and coordinate away rotations to help augment and increase specific experiences depending on resident-specific goals. Sports medicine elective at Greater Lawrence Family Health Center and University of Massachusetts in Worcester are encouraged as well. We also support and recommend attendance at local and national sports medicine conferences. As I said, we'll have monthly journal club review and check-ins. The AOC also requires a scholarly activity or QI project relating to sports or musculoskeletal medicine. There are often opportunities to participate in community-based engagement activities and lectures as well. Last but not least, our AOC graduates would also say that we have a lot of fun.
Hi, everyone. My name is Jenny Summers, and I will be talking about the Innovation AOC. The Innovation Area of Concentration is a new area of concentration at Lawrence Family Medicine Residency Program, and I will be talking about it with my colleagues, Hannah Pearson and Julie Scott. We created the area of concentration in innovation to allow residents to create a new AOC with support from faculty. This is in the case that a resident desires to plan an area of concentration that LFMR does not currently have, and it is a collaboration between the residents and faculty to create a new AOC plan. It is then submitted to leadership to review. The AOC plan is reviewed on the following characteristics. The area of concentration accomplishes goals otherwise not in the current curriculum. It is a detailed and organized plan that is likely to meet those educational goals. It has feasibility within our current resources and is logistically possible with our scheduling demands, and we will also review the financial implications. I'm now going to introduce Hannah Pearson and Julie Scott, who will talk about their Innovation AOC that they created last year and have currently started.
My name is Hannah. I'm one of the residents that started the Maternal Child Health Innovative AOC along here with Julie. Our AOC was really born out of a desire to have more deliveries and have more time managing and evaluating labor. We're also really interested in learning more about the postpartum period and learning how to best support moms with breastfeeding and their concerns with this big transition in life. We also want to have advanced training in lactation, and eventually, hopefully, we'll be getting our IBCLC and working with Dr. Summers on developing our skills in lactation. We also wanted to become experts in several different women's health procedures, including infertility, pregnancy of unknown location, contraception management, including LARCs, and endometrial biopsies.
Hi, my name is Julie Scott. I'm also another resident who is participating in this Innovation AOC with Hannah. So we named our AOC the Maternal Child Health AOC, and these are our goals and objectives for this AOC, or area of concentration. So we wanted to ensure that the residents have more maternity care rotations, so we spend more time in our hospital delivering babies and managing other residents while they're delivering babies and having more of that senioring experience. And during those times, we also have advanced lactation training with IBCLCs on the maternity wards, and also spend time with Dr. Summers in her clinic. And then hopefully we'll be able to sit for the board exam as well. And then we also have included colposcopy training in our AOC. So we do colposcopy clinics here and really get hands-on education with that, as well as other women's health and reproductive health clinics that we have access to here. And we also will do POCUS training, especially first trimester ultrasound training to help date pregnancies. We work with our experts here on that. And then lastly, we wanted to include some like quality improvement projects and scholarly projects on maternal child health in the area. And we work with some community partners on just improving access and education for maternal child health as well. Thank you for tuning in to hear more about our Innovation AOC. And if you guys have any questions, please reach out to us.